Okay, there we go. We're recording. So good morning and either welcome or welcome back everyone to our series on our new community health profiles overviewing the health inequalities and health needs of different community groups. Today, we're going to be focusing on the findings from our Gypsy, Roma and Travellers community health profile and overlooking some of the health inequalities and some of the next steps of what we can do following this webinar. So we've got a pre-packed agenda today, but there should be a good amount of time at the end for some Q&A. But just to give you an overview of what we're looking at today, so in about 5 minutes, just getting everyone set up and into the meeting. We will be using Mentimeter, so it'll give us a couple of seconds to kind of get familiar with that platform, just so it's not just me speaking at you for an hour. There's a lot of time then for interaction throughout the webinar, as well as the Q&A and discussion at the end. They're going to spend about 10 minutes going over some demographic insights, so looking at geography, looking at population overviews. Then we're going to spend about 15 minutes looking at some of the key health inequalities that we picked up from the report. I'm just going to preface this by saying that this is not going to be a complete comprehensive understanding of every health need of everybody that identifies as Gypsy, Roma or Traveller, as this is only a 1 hour session and should be a good start point for learning and kind of developing that understanding further. But please don't take this as a fully comprehensive understanding of everybody's inequalities. Then we're going to look at about 5 minutes of how we can use these findings in our work and how we can develop on this, maybe any kind of feedback and things like that. And then we do have some ongoing and upcoming funding opportunities to work closely with these communities to kind of tackle some of these health inequalities. So just some very generic housekeeping rules. I just kind of suggest that everyone stays muted and turns off any VPNs to let things run smoothly. This isn't saying you've got to be quiet for the whole hour, and I'm not wanting anyone to talk. You're more than welcome to talk, put your hand up and discuss. It's just while the slides are ongoing, just to make things run nice and smoothly. There should be a Q&A feature in the chat, and on Menti that we'll be using, there should be an anonymous Q&A feature. So if it's not something you're comfortable with asking out loud or want to put your name to, there will be somewhere you can type down any questions as well to pick up. We will be emailing out these slides, hopefully by the end of today or tomorrow morning, whenever we can get them uploaded to the website and on the Healthy Brum YouTube channel. And again, this is being recorded and uploaded to the Healthy Brum YouTube channel. You will also be sent the link to the recording as soon as it is available. So just to kind of get everyone set up on Menti, for those that haven't used it before, it's just an online kind of interactive software. We can kind of ask questions. We can look at some kind of interactive quiz aspects of it. If you've not used it before, you can either access it through a desktop or through a phone, and you can either scan the QR code on the screen. You can go to www.menti.com and enter the code 81029227. And Reese has just put those details in the chat, as well as a link to join on to that as well. So I'll give everyone just a second to get familiar, but you should be able to still join the Menti. The code is still going to be at the top of all of these slides. So just see if everybody's kind of got on there and see what the kind of the environment in the room is, see where people are coming from, what people are looking forward to learning today. Is there something in particular that has piqued your interest about these webinars or something that you'd like to talk about? Again, if there's like a common theme that emerges and that people are interested in, I can spend a little bit more time focusing on that than maybe other aspects of the presentation today, just so I can kind of see where people are coming from and gives people a chance to understand how to use Menti. Nice that someone's looking forward to some interaction, so we'll get plenty of that throughout the course of today. Learning more about the community. Yeah, as I said, this is going to be kind of a really great start point, good overview. I would recommend that anyone that's kind of found today interesting by the end of it to go and read the full report. It is, I think, like 150 pages long, plus there's lots of data tables and there is some additional resources as well. Just because I say there is so much information in these communities, it's not going to be comprehensive today. And absolutely something, say, really interesting point that someone's put up there, how we can kind of challenge the narrative about racism and discrimination. And that's something that we're going to see underpinning almost all of the inequalities that we talk about today, is the experiences of racism and discrimination against our Gypsy, Roma and Traveller populations. And someone's interested about demographics. Okay, we've got plenty of that today then, so we're all in the right place. So it looks like we're all using Menti fine. So I'll move on. I'm going to give a really quick overview at where we've gotten this data from, but I'm not going to spend too much time going over the ins and outs of it. Some of you have already heard this before because we did have a little taster session of this back in November. And also, I want to spend more time today going over the actual health needs and the discussions rather than talking about the profiles as a whole. But for anyone that's not overly familiar with the profiles, they are a key set of resources that we've developed here in the Public Health Division at Birmingham City Council. And they look at summarising the physical health, the mental health, the lifestyle, the behavioural factors, and some of those wider determinants of health-related issues, focusing on a specific community or specific communities. And they look at going away from a shift of kind of homogenising communities in just wider acronyms like BAME or LGBTQ+, or even in this case GRT, and homogenising communities together, where there's actually significant and different health outcomes between specific population groups. We have the full report available on the website. I think Reese has just put the link in the chat. There is also a quick infographic summary for those that like something a little bit more visual and a little bit less intimidating to look at. It's just a one-page kind of pulling out those key statistics. And if anyone's interested in the actual research and the methodology that went behind this profile, we have an intro to community health profiles video, which is about 20 minutes long and goes through things like what databases were searched, what community search terms were used, what all of the kind of the scientific side of it is. So if anyone's interested in that side of the research, please go and watch the video. So today I want to focus just specifically on the profile. So I'm going to start off with a little bit about the data and how information on these communities have been collected and some of the feedback and some of the changes that we kind of suggest going forward and kind of what the next steps are there. So in the 2021 census, Gypsy, Roma and Traveller identities were in the top 20 ethnic groups under the white ethnic group umbrella. So there was the two relevant categories that we've analysed, the white Roma and the white Gypsy or Irish Traveller. So although we could get lots of analysis from that, it may actually not be the most appropriate. A lot of people that identify with these categories don't identify with that white overall umbrella. So we'd really recommend, and what we have created is a standard demographic data collection tool that's just removed all of the prefixes of white, black, Asian from these different ethnic categories and focuses more on people's specific identity. So instead of it now saying white Roma, it just says Roma. And we've also now got an open text box talking about people's heritage or countries of heritage. So you can get that more kind of comprehensive understanding of someone's identity in a way that's more reflective. And why this is important to talk about, especially for these communities, is based on some of the findings from the 2021 EVEN survey. So that's the Evidence for Equality National Survey, for those who aren't familiar. And it showed that a really high proportion of people from Gypsy or Traveller, and that was at 90%, and Roma at 70% of ethnic groups reported that that ethnic identity was really important to their sense of self. And this compares to only about 46% of white British people. So actually getting terminology right is something that's really important in this instance. And also, again, kind of highlights making sure that we're listening to community voices. And that is something that will help overcome some of those negative barriers, is that interactiveness and listening to people. We've also avoided in this profile and in all of these presentations using the acronym GRT, which is quite often used in a shorthand in a lot of government-based reports, just based on community feedback that it's not reflective. And although there might be some similarities between Gypsy communities, Roma communities, travelling communities, there's going to be big differences. And if as a council we're going to commit to moving away from acronyms such as BAME, it makes sense to do the same thing and move away from using homogenising acronyms such as GRT. It seems very fitting to not want to group one together and then group the other together. So there's a wide variety of language that's going to be used to understand and identify ethnicity and identity, and important that it's going to be unique to everyone, and it's not going to be one kind of overall picture. There are also a lot of kind of caveats and limitations in all this data collection. If we move on to the next slide, please. First of which, when we're talking about terminology, in the profile and different data sets, there's no standardized way of use of collecting data. So actually different sources use all sorts of different varieties of terms. So in some reports, they report it as white traveller of Irish heritage, some report it as Gypsy/Traveller, some use just Roma, some use Gypsy or Irish Traveller. So it's really hard to understand the specific health needs when there's no standardised way of understanding this health and well-being. And in most government and national data sets, these communities are just invisible and aren't collected at all. So there are some huge barriers there. And as I talked about before, they're collected under that wider white ethnic group category at the minute, which may not be appropriate. Specifically in this report, we've highlighted in single quotation marks the specific wording that's been taken from those specific sources, just to make it a bit clearer, because it can be very confusing when there is such a variety of terms that are used in, say, non kind of standardized formats. Again, when we look at the reliability of this, because of those huge experiences of racism and discrimination, there's a huge underreporting of people from these communities because there's a lot of barriers to self-identifying in these national data sets. And when we look at the population numbers in a minute, you'll see that huge disparity between some of the population estimates that we have and what the overall population reported in the census is. And lastly, in the report, some of the variables are unadjusted, so this means it doesn't take into account some of the other demographic factors. Additionally, one thing that I just kind of want to talk about as well is there's going to be just limited information, and this is across all of these different profile webinars that we've had, is that there's a limited understanding of intersectionality within pretty much all of these reports, that someone's identity isn't going to be just exclusively linked to their ethnic identity or their heritage, but there's also going to be their age, the gender, your sexual orientation, people that have a disability that are going to have compounding experiences of inequalities and different experiences with healthcare settings. And that's going to be kind of across every community, that you can't just look at someone's identity in complete silo and assume a full background of health and well-being. Okay, so we're going to go over a little bit about demographics, but what I kind of found really interesting when reading this report is the difference between the estimated population and what is reported in the census. And this is highly linked to that the discrimination, those barriers to self-identifying. So we've got a little bit of a quiz on what we think that the estimated population size is in the UK, and actually compared to what the reported is, you'll see the huge difference there. And just while people are answering that, I'd really recommend, Simon always put some really useful comments in the chat and really highlighted about the term Gypsy and its controversy and whether or not people align with it or not, and moving towards using Romani or Romani. And it's, again, a very serious debate within the community on whether or not it is an appropriate term or not. So just really highlight any kind of comments in the chat, please kind of put them up and kind of read some of Simon's really useful feedback here. Just one more second. So we've got quite a mixture of different kind of votes here. The majority going towards kind of those that 100,000 or 250,000. If we kind of go to what the correct answer is, it's 500,000 is the estimated population size. So when we go into what the census estimates are, it actually says there's only around about 170,000 people that identify with either white Gypsy or Irish Traveller or white Roma. But because of those barriers to self-identifying, some other resources have actually indicated that it's closer to 500,000 in the UK, which actually is a huge portion of our population when we look at some of these different community groups. But there's just a huge underreporting, which again also then leads to a huge gaps in knowledge of what we know about the health needs and how to appropriately address these. And overcoming kind of that barrier to self-identifying and the discrimination faced is a huge part of going towards understanding the health and well-being needs. In Birmingham alone, said the actual census population was 1,833 for white Roma and 686 for white Gypsy or Irish Traveller, but kind of take that with a huge pinch of salt that it is likely much bigger than this due to those barriers. When we look at some of the other demographic overview, the census also gives us some indication of religion and faith, of main language and of national identity. In terms of religion, it's predominantly a Christian community. However, again, this is going to vary depending on the specific subgroups that you look. So when we look at people from like Irish Traveller backgrounds in particular are known for more Roman Catholic beliefs, but someone like a new traveller might have a more wide variety of faiths or more likely to be non-religious. So again, it's not one overarching picture. Language is something that is interesting in the census because we can only get information on main language. And in the census, other European languages was given as the main language. It doesn't break it down any further than that, unfortunately. But some more context. English was reported as the main language for 48% of Gypsy or Irish Traveller populations and 23% of Roma populations. And other European languages was reported as the main language for 51% of Gypsy or Irish Traveller and 76% of white Roma. Now, in the census, it identified that less than 5 people that identified with these communities had Romani as a main language, but it's important to consider the importance of language, especially as an additional language, and the cultural importance of something, even though it might not necessarily be reported as someone's main language in the census. So using that mixture of data and intelligence, but then community understanding and really involving the community in some of these decisions and understanding. And with national identity, primarily we're looking at people with a a non-UK identity, which means that they identify with another country of origin or heritage. But again, it doesn't really provide us much greater detail than just that overview. Now, the census also provides us with a good overview of geography. Again, this is going to likely be slightly different than the true picture just based on those underrepresentation in the population side, but it's useful to have a little bit of context in terms of geography for a place-based approach, about community events or health interventions. But again, the places where people live may not necessarily always be the place where the community engages. With the traveller population, you are going to have some that are still travelling. There are going to be some that live in bricks and mortar. So again, that's going to be a completely different understanding of where the population are, how they live and how they engage. For people that don't know about the different acronyms on this page, OA is just about output area. So this is where we can zoom in to look down to areas of about 310 residents. So although in Birmingham, the population of white Gypsy or Irish traveller ranges from less than 0.1% of the population of 0 to 0.5, there's actually one output area where 11.5% identify with this identity. So it's really variable across the city. And an MSOA is a middle super output area, around about 2,000 to 6,000 people. So just giving us a little bit more context than just looking overall at like a ward or a constituency level. But because, say, it's useful to know where community engages, again, it's that using that mixture of the data-led approach and community intelligence. There is also another map that looks at the Roma population, and actually the population distribution was in quite different areas of the city compared to the Gypsy or Irish traveller population. And the most densely populated part of the census map here is in the central MSOA, so in the central parts of the city. If anyone's not used the census map before, I would highly recommend kind of going on and having a little play with it. It's a nice way to visualize some data if people are kind of a little bit more visual rather than just looking at lots of stats and tables. So something that I particularly quite like. So a small demographic overview there, but again, probably not the most comprehensive and deep understanding from the census underreporting of populations, but gives us some sort of start point. And I just, again, want to highlight the importance of using not just the data, but that community intelligence in all approaches with all communities, but especially when we're talking about the big disparities between the actual and the reported populations here. So I kind of want to understand people's knowledge in the room of where we're starting in terms of people's confidence with health needs and kind of how confident people feel in identifying the health needs specific to these populations. Potentially think about how much you know and compared to other population groups. So I can kind of have an understanding of where we're starting at in the room. So are people really confident on this? Do people know nothing? And again, if you know nothing, that's fine. I'm glad kind of you're here today and are willing to learn and to develop that. And if you're someone that's right at that very confident end, you're someone that's also probably going to be really supportive in being able to help the other people in the room upskill their own knowledge. So I think the most people in the room are sitting towards that kind of lower end of that not confident at all range. So hopefully this gives you kind of an overview of some of these health needs. I just want to keep kind of reiterating, this is not going to be a fully comprehensive understanding. So before we get into looking at the different sections of the report, I don't want to just jump in straight to getting the best start in life and going through the sections of that. I wanted to start with experiences of discrimination because this is something that comes up, unfortunately, in every single area of the report and has huge impacts on every aspect of whether it was schooling, whether it was access to healthcare services, whether it was mental health. These experiences of racism and discrimination were a huge part of this report. Actually, it's one of the people that were from English, Romany, Gypsies and Irish travellers. Almost half of them experienced harassment purely based on their background. Actually, in terms of racist assault for ethnic groups, people from Gypsy and traveller backgrounds had the highest reported amount. And this isn't even taking into account that a large portion of racist attacks are not reported, even though there's some kind of, we're looking at some protected characteristics. Only about a quarter of racially motivated instances of discrimination were reported. Only about 10% of physical attacks were reported. So even though we already have huge experiences of racism and discrimination, this is still going to be an underreporting of what that true picture is. Again, a lot of the time because of this fear of discrimination, even from the people that is going to be reported to. So when we kind of look at, just keep this in mind when we're going through all of the different sections. I'm only going to, because of the nature of time today, look at one key piece of data from each section, just to highlight not necessarily what is the most important inequality or what shows the biggest disparity, but generally where we have good quality data to be able to make make these conclusions, because, as I was saying, in a lot of national databases, these communities are invisible and are not reported on. So actually making some really clear conclusions are really difficult from the data alone. So when we're starting with getting the best start in life, I'm going to start looking at education. So overall, we typically see some of the poorest educational attainment out of every ethnic group in the UK. And we can look at that either through Progress 8 scores or GCSE attainment. So Progress 8 scores, for those that aren't familiar, looks at how much progress a pupil makes between the ages of 11 and 16 across 8 core subjects, compared with other students that have similar starting points at age 11. A score of less than 0 typically shows that a pupil makes less progress by a grade or more in England compared to those that has similar Key Stage 2 results. So we can get Progress 8 scores of the Gypsy and Roma populations and the Traveller of Irish heritage, and look that they're both below that 1 mark, so showing poor attainment compared to those with similar start points. So that's kind of showing a lot of the time is because of these barriers to education that you see on the right, which I'll go through in a minute. And again, in terms of GCSE attainment, so those that are achieving that grade 4, so that standard pass in English and maths, only about 20% of Gypsy or Roma populations or 33% of white Traveller of Irish heritage are meeting these grades, compared to about 68% of the white British population. Now, in Birmingham, some of this data may not be accurate because, again, of the small population size that has self-identified. So in Birmingham, there was 1,135 pupils from a white Gypsy or Roma background and 30 from a white Traveller or of Irish heritage from academic year 2022 to 2023. So some of these results may be skewed based on individual population numbers when we're looking at a small sample size like this. Now, with the barriers to education that may be contributing towards some of these educational outcomes can be categorised into 3 main different groupings, the first of which being institutional barriers, so having that lack of cultural visibility of the cultures in school curricula, having a reduced availability of appropriate vocational courses, having a lack of engagement and cooperation between local authorities, between the schools, between different regulators communicating to families effectively, having limited funding for dedicated traveller education support services. So there are institutional barriers preventing kind of children from achieving the best they can at a GCSE level. We've also got attitudes. So again, this is going back to that experiences of discrimination, that there's an assumption that teachers just expect that children from these backgrounds aren't going to achieve, so may not necessarily put the time and effort and resources into investing into these children. There's going to be, again, those experiences of and fears of bullying or discrimination. And even those that don't necessarily have those opinions of discrimination and racism, there may be unconscious bias from other students and staff that may impact these children, and a failure of the school to kind of respond to some of these instances. And the third of which can be categorised by characteristics. So again, when we look at English literacy, English was not a main language for a large portion of these populations, and there's that kind of lack of support in that area. There may be kind of difficulties in adhering to the specific school routines and having that lack of flexibility there. There may be, in some populations, disrupted educational experiences due to travelling, but that's not going to apply to all of these travelling communities, and kind of that lack of communication between the local authorities and schools to provide that continuity for the children. And again, the educational kind of expectations of the teachers, potentially of the parents, and some concerns about undermining community values in the schools and not kind of appropriately respecting these different community groups. If we look at mental wellness and balance, again, we get a bit of a variety. So in looking at the GP patient survey, we have a prevalence of self-reported mental health conditions. But again, this is because this is self-reported, it's going to really depend on what communities perceive as poor mental health, whether or not it's something that is going to want to be discussed with a mental health professional. And this has come up across multiple different community groups, that just because a population reports that they don't have a very high prevalence of poor mental health might not necessarily reflect the true picture. And we've discussed that in a couple of other webinars, that actually it's aligned. There might be low use of mental health services, but actually high rates of compulsory admission or high rates of access in emergency situations. So again, the statistics are taken with a pinch of salt when we talk about mental health, because of the stigma in a lot of communities around talking about your own mental health. When we look at the actual statistics of what we have, 29% of white Gypsies or Irish travellers reported poor mental health conditions, and compared to only 14% of white British. 6.6% of white Roma reported poor mental health conditions. But as I said, this may not be reflective of the experience of mental health, but may be reflective of people's ability to discuss it in a safe environment. There are many factors associated with poor mental health. I'm not going to kind of list them all off. Some are on the screen. Again, you kind of see in some of those going back to racism and discrimination, again, some of those negative stereotypes. It's something that underpins all different aspects of community health. We also can look at experiences of insecure or inappropriate housing, which we'll touch on a little bit more later, about the actual availability of safe travelling sites. We have kind of a loss of freedom of not being able to kind of experience one's culture in the way that you might want to, all of those kind of compounding factors to mental health. And kind of talking about, particularly around men, this is not unique to the travelling community, but around that stigma and that fear around talking about mental health, and men are known for not going to mental health professionals or just talking about health in general as much as women do. When we look at kind of food, there is very little evidence that talks about diet, nutrition, or body weight. There is a systematic review that was identified. It's a little bit outdated, so I'm not 100% sure on whether or not it would continue now, but it looks over a 10-year period and looks at Roma versus non-Roma communities, and kind of identified three main outcomes: that there were diets higher in fat, cholesterol, and animal protein. There was a higher risk of poor nutrition, and there was higher prevalence of abdominal obesity and overweight status. So there is a potential link between being Roma and having poor diet, but again, there's no national database that can confirm one way or another. Again, there are some barriers to healthy eating, talking about the cost to some of those healthy eating foods, the practical problems of, again, having inadequate facilities to cook or to store fresh food, and again, reverting back to the living conditions. And a different study actually looked at almost 1 in 10 people from English, Romani, Gypsy, or Irish traveller backgrounds went to bed hungry in the last month just because there was not enough money for food. So again, food insecurity is something that may be an issue in these communities. When we look at living, working, and learning well, I'm going to kind of be looking at, again, at that health and well-being and that access to health. So we typically see a significantly poorer health status overall and a higher reporting of long-term illness and disability compared with the general population. There are a lot of barriers to accessing care, so a lot of these conditions actually could be minimised if there was early intervention and support from the get-go, but in a lot of cases that's not necessarily seen. And in this kind of data set, 68% of people from white, Gypsy, or Irish traveller background reported having a long-term health condition, compared to 58% of the white British population. And health status, we see, is linked quite closely to quality of accommodation type and quality. And in an update from September 2020, it was found that there are actually only 2 functional active travel sites in Birmingham, one of which is currently closed, and the other site only has a capacity of 14. So there's actually very minimal kind of safe living conditions for traveller populations that still wish to not live in kind of bricks and mortar accommodation, which can contribute significantly to experiences of poor health. And again, with some of those barriers to accessing care, there are some instances still of difficulty registering with a GP due to lack of documentation, which should not be an issue. But again, because of those experiences of racism and discrimination, a lot of the times these populations are just kind of passed off, and the GP kind of does not want to kind of go through the barriers to get these people signed up to a GP to access that care, to overcome some of these or manage some of these long-term health conditions. And in general, it kind of comes in hand, is that cultural competency of the staff and the understanding, because it's like these populations are quite often hidden in national data sets. There's not that same breadth of training and data and understanding to make sure that care is provided in a culturally appropriate way compared to maybe some of our other more well-known population groups. So moving on to a bit of protect and detect, again, you see the similar picture that there's not really much routine data on screening, on vaccination, on sexual health, or infectious diseases. But there again are some systematic reviews that maybe link Roma populations to things like influenza, bronchitis, infection, which again, if you link that can be quite often linked to kind of experiences of your living environment. There are some, again, barriers that have been identified to attending some of these screening programs of vaccination that are going to be very similar to what we've seen across all of these other ones. So those limited tools to identify population groups. So would really go back to those standard demographic tools that public health has collected to make sure that these population groups are captured in these data sets, to make sure that we understand the populations more and can provide then the appropriate targeted health interventions and healthcare needed. Again, talking about language and literacy, so providing information in the right formats, in the right language, maybe having, even though we talked about Romani not being a very common first language, developing resources in that language because of the cultural significance, maybe using some more visual tools instead of really lengthy written English documents. And again, that experience of discrimination quite often comes hand in hand with the mistrust of health professionals. So just being really kind of open and willing to learn and discuss kind of is an important thing to build that trust between healthcare professionals and the community. So just finishing off, so I know kind of I've whistled through a lot of different information at the minute, so I'll stop talking in just a minute and we can get through to some discussion. When we look at overall ageing and dying well, the life expectancy, this is in the UK compared with the general population. So because of all of these experiences of education and housing and those wider determinants, the barriers to accessing healthcare, especially looking at preventative healthcare, actually leads to lower life expectancy. So this is up to 10 to 12 years lower in Gypsy and Traveller populations and 2 to 10 years lower among Roma populations. So we're looking at a difference of a decade of life experience based on some of these health inequalities. So really compounding health inequalities that leads to these experiences. And again, we've got higher mortality risk and excess mortality kind of across all categories in Roma populations compared with non-Roma populations. This again was come from a systematic review on mortality that included English, Romani, Gypsies, Irish travellers and Roma from Central and Eastern Europe. And it also found that deaths often occur in more traumatic circumstances and often as a result of road accidents or unfortunately suicide. And again, when we talk about these kind of bereavement, it's something that in the communities it's not necessarily spoken about, and it really highlighted a need for having specialist bereavement services and support. And again, a lot of these early deaths were often resulting from undiagnosed cancers, uncontrolled diabetes, poor maternal infant health, cardiovascular disease. And when I kind of list off that, these are mostly preventable determinants of poor health and can mostly be controlled by appropriate healthcare and early intervention. As I said, this is not a comprehensive understanding. There are many other kind of key health inequality data in the report. So we talk about, next slide, please, Alex. There are other things like maternal and infant outcomes. So there was the highest maternal mortality rate across all ethnic groups identified, including higher rates of miscarriage, of stillbirth, of low birth weight. We're looking at experiences of child poverty and children in care. So Gypsy Roma children were 2.1 times more likely, and travellers of Irish heritage were 2.6 times more likely to be living in state care compared with children of all ethnic groups. There was the lowest access to outdoor space, so 68% of Gypsy or traveller populations and 54% of white Roma populations had access to appropriate green space compared to 95% of white British population. Also, the experiences of living in areas of pollution. So when we looked at the census map at the beginning, there was typically the population concentrated in the inner parts of the city, which meant that around about a fifth to a quarter of the populations lived in the top 15 most polluted neighbourhoods compared to 5% of the white British population, which actually things like particulate matter can contribute significantly to excess mortality. I think it was around about 5 or 6% of all deaths in Birmingham were associated with experience of poor air quality. And again, looking at that social exclusion. So because of the experiences of racism and discrimination, one study reported that a third of English, Romani, Gypsies and Irish travellers felt completely excluded from society. So again, that ability to be able to engage with mainstream school services, mainstream healthcare services are kind of really kind of impacted by that feeling of complete social exclusion from the rest of society. So as kind of this whistle-stop tour has kind of given an overview that there are some stark health inequalities that are experienced by Gypsy, Roma and traveller communities within the UK and within Birmingham. There are multiple factors that have been identified that can inform the design and implementation of work to address some of these health inequalities and improve health and wellbeing across the city. And overall, we can kind of summarise it by saying that the combination of suboptimal living conditions, of social exclusion, of low educational attainment, and of widespread prejudice and discrimination leads to a lot of these poor physical and mental health outcomes, in addition to that poor access to services. So one of those kind of main things, it's important to decrease this kind of stigma and this experience of discrimination to enable that kind of social cohesion and make people feel more included in those services and therefore access them more appropriately. But again, this presentation and this profile is kind of a start point to building those evidence summaries and is not fully comprehensive that will accurately map the experience of all Gypsy, Roma or Traveller communities. So it should be used as a starting point, and you should absolutely use kind of community voices in addition to the evidence when building any community health interventions. So I'm aware that I've kind of given a lot of information, so we'll take a little bit of time. We've got some, again, kind of see how people kind of felt that has change their knowledge. We will then talk a little bit about kind of some opportunities for feedback that we have and those funding opportunities, how you can use this. And then we've got some slides. We've got kind of 3 slides looking at some of that discussion. And then hopefully we should still finish off with around about 15, 20 minutes of open discussion for anyone to ask questions or to kind of share any kind of experiences they will with the group. So it's nice to see that's kind of shifted from around about the 2 to around about the 3, but yeah, kind of having that understanding that it's just going to be a start point and is not going to be, you're not going to come away from this going, I'm an absolute expert now in Gypsy, Roma, Traveller population health, and I'm going to be able to do everything perfectly. That it's always going to be kind of that continuous learning journey. So it's great that kind of everyone's attended today and we can kind of start that ongoing kind of professional development and can keep this learning up. So the next step, so what do we kind of want people to do following this webinar? So the first thing is profile review. So at the minute, this is all of these reports are in draft version, and we encourage everyone to kind of go and read either the full report or an area of interest, and we're completely open to feedback from multiple perspectives. So if you're someone from one of the Gypsy, Roma or Traveller communities that kind of wants to discuss experience of healthcare, anything that might be missing from the report, any areas of health that are particularly important to you that have not been reflected in the report that you think is important for healthcare professionals to know, we can look at including. If you're a healthcare professional that has worked in this field before and we've maybe not captured a piece of work that's been going on or something that you think would be really kind of strengthening this, we're more than welcome to kind of have a discussion. So you can either write to us via our community's inbox, or we will be setting up at some point soon face-to-face or online sessions if you kind of prefer that format of talking. It's kind of whatever works best for you. We really want to kind of make it clear that this is a kind of a two-way piece, that kind of our feedback, we'll kind of appreciate kind of any feedback from any perspectives to make sure that any kind of data we produce is, 1, the most comprehensive of what we do have, and 2, is the most reflective of community experiences, because there's not much point us producing a report to say this is the health of this community and then the community turning around and going, oh, actually X, Y and Z doesn't reflect my experience. So that's kind of where we're at the minute. In terms of where you can kind of take these findings going forward, so we kind of really appreciate reading the report, but where can you share it around? So maybe thinking about any team members that might be interested in this work, the wider organisation. If we can go on to the next slide, please, Alex. Any partner organisations that you work with, any community organisations that work with the Gypsy, Roma or Traveller communities that again might be able to kind of provide that really useful feedback and development. How can we potentially use the findings in this? So you could potentially use the section of the report that you're interested in to reference in a new project, to look at having some of those findings in project services and proposals, to be an advocate for the communities and influence decision making with relevant stakeholders to make sure that the decisions made are going to be appropriate and relevant to these communities. And potentially, if you're not in any of those spaces, just acknowledging some of the inequalities and some of the points we've talked about today to make your daily practice more inclusive and have that in kind of the back of your minds when making your decision making on a daily basis. So we've got a little kind of bit time for some discussion, so I can stop talking at you all for so long, kind of talk about some kind of sharing of ideas and what we can do going forward. So do you kind of have any kind of inspiration for how you envisage using this? If you don't, someone else might do. It might be a great kind of place to take some inspiration from on how we can kind of support each other in using this work to improve the health and well-being of these communities. there's nothing that comes to mind at the minute, then we can kind of come back to it. You should be able to still answer the question on screen. So if we kind of move on, I want to make sure we get some time at the end for kind of open discussion, so I don't want to spend too much time. Oh, there we go. We've got a couple now. So sharing with colleagues, kind of sharing it out. Absolutely. So awareness is definitely kind of that first point of where we can kind of start from, is making sure people at least are aware of these inequalities and can acknowledge them moving forward. So you can't move straight from knowing nothing to being an advocate for a community. So definitely kind of raising awareness and signposting. The report also highlights some really good community organisations that work closely with these communities. So for example, it quite frequently mentions friends, families and travellers. So there's some really useful signposting in the document itself. Thank you. Also, moving on. And this again might be more appropriate for anyone that has particular experience already, but what can kind of healthcare professionals in the room take away from today to become more inclusive? Or is there anything that kind of you feel inspired to do to become more inclusive going forward? Definitely, I think something that's really important that's been highlighted today, to listen to community voices and kind of having those real co-production pieces and making sure that people are involved as equal partners, and it's not just us doing to the community, but the community kind of telling us what their priorities are and where kind of they want to be, how they want to be involved, and not just kind of us dictating that. Yeah, absolutely, involving at every opportunity available, having lived experiences to drive that change. So again, that quantitative data only provides us one kind of key insight, but having those really kind of lived experiences, I think, is something that is really important. And kind of, I think a lot of people like to actually hear from real people and real people's experiences. It makes it feel a lot more personal and a lot more kind of connected to one another. And you kind of a lot of the times, regardless of whether or not you have a lot in common with people from different communities, there's going to be those shared experiences, and you're going to be able to connect over a lot more than there are different. So having people's kind of lived experiences can really resonate a lot of the time. Thank you. So last kind of one. I just noticed the time's going to try and speed through, so sorry for rushing you all. And is there anything else from kind of our point of view that would be helpful for you to have to improve your practice? So if you kind of come away from today and go, oh, actually, this was useful, but I'd really like to have X, Y, and Z. And we can kind of look at maybe introducing some of those or implementing some of those in our work going forward. Examples of good practice. That would be really useful. Yes. Okay. Thank you for that. And I've noticed a couple of people in the chat, just kind of as a side point, really useful to see that a couple of people are kind of already doing work in this space outside and would like to kind of talk about this. Whether if anyone else is interested as well in, even if you don't currently have any pieces of work ongoing in this area, but kind of want to talk about potential opportunities, please reach out to us. Arts and culture, absolutely. Say, I would highly recommend reaching out to Reese who's on our team and has been putting everything in the chat if you're interested in arts and culture, as that is kind of entirely that aspect of our work stream in our team. It's focusing really on the importance of how art and culture and community can really impact people's health and well-being, and how important arts and health are to kind of all communities. It's not kind of exclusive, but really kind of embracing specific culture. Thank you. So I've just noticed the time. I'm going to quickly kind of whiz through the last couple of slides and then go through to some discussion. So apologies, I'm kind of running a minute or two over. But I really kind of want to highlight at the minute, we do have an open opportunity for some engagement work. So we're looking to work closely with a community organisation that is either representative of or already works closely with Gypsy, Roma or Traveller communities. It's a 12 to 18-month contract that focuses on projects addressing health inequality and also looking at sustainability and upskilling the community, involvement with different council forums. So if you're interested in this, there is a Find It in Birmingham link that Reese can pop in the chat. However, if you don't have an account at Find It in Birmingham, because it is behind a paywall, please email us if you're interested in the opportunity and we can share the documents directly. We don't want a paywall to be something that puts a barrier in place to a community organisation applying. So just make sure that that's really clear. Our deadline for applications is around about a month from now, so we have until the 12th of April. If anyone, again, wants more information or wants a little bit of a discussion about the opportunity, please feel free to reach out to us and we're more than happy to kind of have a chat about the opportunity. Now, we do have 11 webinars going on at the minute. 3 are already live on the Healthy Brum YouTube channel. So if you found it interesting today, please kind of watch the other webinars. We have another series upcoming, so please sign up if you're interested in them. But this will all be kind of circulated after. I also want to quickly point out that if you've already used any of the previous community health profiles, that we have an ongoing evaluation. I can see that Layla is attending today. I don't know if you want to say a word or two, or if you've kind of seen you put it in the chat, but up to you whether or not you kind of want to talk about the evaluation for a quick second.
Hi everyone. Thank you. It's lovely to hear about these community profiles. And what we're doing is we're trying to understand how these profiles are useful in the different communities and in Birmingham and across the UK as well. So we have this short survey that we put together to help us best understand those that are using it, those that are designing it, those that use it in different contexts. If you could please fill the survey. It's a very short one. Let us know what you think about it. If you want to have further conversations about it too, we have an email address attached to it. Give us your details and we will contact you to discuss it further. Thank you very much.
Thank you. And that brings us to the end for today. So apology, I've kind of ran over, but we kind of have a little bit about an Ask Me Anything. So anyone that wants to put something on the Menti, or if you want to kind of raise your hand, want to talk, come on camera, whatever you feel more comfortable with. So we have one on the Ask Me Anything. I think that kind of relates back to one of the old questions about kind of not judging and being more understanding. But does anyone have anything else that they'd want to discuss or any questions that they have following today's webinar? Can't see any hands at the minute, but what I will do, I'll pop the kind of contact details on screen. Again, this will be circulated out and I will turn the recording off if anyone wants to ask any questions off recording in a minute. Oh, Simon, there you go. Hi.
Hello. Hi. So thank you, Jordan. I mean, it's a very difficult following that. Again, just thanking Ricky for including me in being part of the research and checking, etc. I think what's really important is it cannot be an academic exercise. That is really important. The impact is so vast that, for myself, it took me until my 40s to re-identify as to my Romany heritage. I grew up traveling, etc. So there's a lot of things in there that I think, again, the community may dispute, but more about it's that the infrastructure has been systematically destroyed over a period of time. You're always going to get the argument from me around the G word, and for those who don't know, it came into being because we were called Egyptians because we were dark-skinned, etc. And then it was shortened to Gypsy, so it's absolutely steeped in racism. But my sisters will argue massively that the G word is about, again, reinventing ourselves, etc. So it's a very big discussion, but I just really thankful, but just to make sure that people are actually thinking that how can it be embedded in, how can we stand up, how can we say things when words that are part of the English language are so ingrained. The word tinker, for instance, is used all the while to tinker with. It's a racist term. you know, and I've had to pull up leading people within Birmingham City Council for using that because there's not an understanding of the language. So I think there's a really long journey that we're going on, and I'm probably, as most of the guys know, the most identifiable person in Birmingham City Council, which has been very problematic, to say the very least, in trying to do things internally. But it's a very difficult place to be as an officer and trying to advocate for a community, etc. So my ask to everybody is, if I would love this year's Gypsy Roma Traveller Month to be something really special. Last year it was non-existent. I'd been asked, you know, if we want to do something, can we, that I've got to do it. I'm one person, but I would love to involve people that actually has a really positive message about what our community has done, the language that that, you know, that is part of the English language, our heritage, etc., that we've always been here, you know, that, etc. So if anybody is interested, you know, I'll pop my email in the chat. But it is really about trying to do the positive, because I'm really tired and a bit triggered right now by continuously hearing the bad, when actually, you know, as communities we do incredible things. And yeah, so thank you. It's not the most concise, but I'm tired, exhausted from hearing all that information. So again, thank you, Jordan.
Thank you, Simon. Simon has been brilliant throughout this whole process, and always really appreciate you kind of sharing your experiences. And I think Simon raises a really good point about being an advocate for a community, that actually if you're part of that community, it can be very tiring having kind of that whole responsibility on your shoulder. So it's important for kind of us as healthcare professionals to support that. And even though we may not be community experts, we can still advocate for and support communities to kind of release some of that burden from putting it all on the community as their responsibility to do so. And you're absolutely right. I know it's kind of useful for healthcare professionals to hear the health inequalities, but focusing on some of the positives and some of the community assets that communities are going to be able to share with one another to help empower each other through arts or through different experiences is going to be just as beneficial to improving the experience of health inequalities than highlighting the bad as well. So that's hopefully something that we'll be able to kind of provide through this, the opportunity with a community organisation to kind of focus on the community assets to improve health and well-being. And again, I think I want to really highlight what Simon said about always being here, that actually the profile highlights that even in reported data that we have, that the travelling communities are some of the oldest in the UK and have been here for a long period of time, and yet still experience some of the worst health inequalities in this country. So it's something that we can kind of take on and not just be like a tick box exercise of like, yes, now we've done this, and something that we can kind of take forward and make sure it's implemented into all of our work. And having some of that understanding of community health and that community intelligence is not going to work just in silo with one community, and some of the things that you learn will be applicable to all community groups, and being able to kind of take that empathetic approach going forward. Thank you. Any more kind of questions or comments for discussion? I'll turn the recording off now as well, just in case anyone kind of has any questions that they don't feel comfortable asking on recording, while we still have some time left in the session as well.